Person School of Medicine. Today's topic is psychiatry and sleep, review of case studies. Let's see, move on to the next slide. Okay. Now, sleep problems are quite common in patients in psychiatric clinics, and if you look at several studies, most studies show that the number is quite big. And in general, we know that 30 to 80% of patients with schizophrenia, for example, had sleep problems. Now, this number varies for other psychiatric disorders. In mental health clinics, people like yourself and psychiatrists, psychologists, residents are the ones who see these patients. And you see patients with sleep problems. So having a good understanding of sleep disorders and how they present in psychiatric conditions and what's the comorbidity between the two disorders will greatly help you understand and serve these patients better. Just to give you an overview of what you will be learning in this talk, you learn about different comorbidities, but it will be categorized as psychotic disorders in sleep, mood disorders, and substance use disorders. You'll hear about a case, and then you'll hear about what are the common presentations as far as sleep is concerned, and then comorbidities between these two disorders, and what are the polysomnographic findings, that is the sleep study findings, and then what are the solutions, and we'll have some discussion about each of the case and these comorbidities. Let's learn about schizophrenia and psychotic disorders and what kind of sleep disturbances do these patients have. Let's look at a case of a patient who's a female patient. The name is Jane. She's a 39-year-old female, unemployed white female who sees a psychiatrist, usually brought in by her mother. Her complaints are that she hears voices, tells the psychiatrist that she is unable to sleep as she is worried a lot about certain things. She's also quite depressed. The voices she hears is, quote, "They'll get me." Now, in terms of medications, she takes olanzapine, which is Zyprexa, Depakote, as well as some other medications. Also takes, over the years, she has gained a lot of weight, and she's found to be pacing at night by her mother. She doesn't sleep very well at night, sleeps a lot during the daytime, and also complains of seeing, quote, "devil's face" as she's falling asleep. She also snores and wakes up with snort arousals. Well, if you were you are a live audience, but it's difficult to have a discussion, group discussion about what kind of sleep disturbances she might have. Now, if you are able to type, maybe we can hear from you. What do you think of what kind of sleep disturbances she might have? Daniel, are they able to type some or no? So let me move on then. So these are the things which we usually bring up in the group discussion regarding this particular case. For example, what are the 4 possible sleep disorders she might have? What medications might be causing some of her sleep problems? And does weight gain contribute to her sleep problems, and how? Does she have insomnia? And does she have restless leg syndrome? Now, if you look at the answers to these questions, the differential diagnosis is quite broad, but it could be that she has obstructive sleep apnea. She could have oversedation with medications. What about narcolepsy? Because she was complaining of falling asleep, feeling sleepy. In addition, she was seeing faces, more like hypnagogic type symptoms. Also, she could have circadian sleep rhythm problems, meaning that her days and night might be mixed. In addition to that, can she have restless leg syndrome? Because she's usually pacing around, walking around at night, as seen by her mother. So she could have all of these. Now, if you go back to the questions for the group discussion, the four possible diagnoses we discussed, that yes, she could have OSA because she's having snort arousals. She could have oversedation. She could have restless legs versus akathisia. In addition to that, possibly narcolepsy, but narcolepsy is quite rare, so we would not put it on the top of the list. Okay. Does weight gain contribute to her sleep problems, and how? Absolutely. Most patients with schizophrenia, when they are put on these atypical antipsychotic medications, end up gaining weight. And due to the nature of the illness, the psychosocial nature as well as the biological nature of the illness, these patients tend to gain a lot of weight, which can then in turn make them have obstructive sleep apnea. And once they develop obstructive sleep apnea, which is most experts believe is a metabolic part of metabolic syndrome itself, these patients do worse. They feel more tired, they have more cognitive problems. Now, the question about does she have insomnia? Well, it's hard to know because she can't fall asleep at night, but then she's sleeping during the daytime. So she may have more of circadian rhythm problems rather than insomnia. And does she have restless leg syndrome? Well, the answer to that is it's complicated because she may have akathisia rather than restless legs, but then these conditions are two different conditions which sometimes can present together in patients with schizophrenia on antipsychotic medications, and it is really important to understand how to differentiate between the two. Okay. I'm going to skip this in the interest of time, but just since we were talking about narcolepsy and that this patient might be having some hallucination, how do you differentiate hallucinations from a person who has got narcolepsy versus the person who's got schizophrenia? Now, in patients with narcolepsy, in general, they could have multimodal perceptual experiences, could be visual, tactile, and auditory, and usually are not accompanied by delusions. In schizophrenia, however, hallucinations they can be visual as well, but in general, they are auditory in nature, and 80 to 90% of hallucinations are accompanied by paranoia or delusional thinking. This is a quote from Bleuler more than 90 years ago. He said, in schizophrenia, sleep is habitually disturbed. Now, sleep disturbance is not necessarily found in the criteria for diagnosing schizophrenia. However, the sleep disturbances are quite common in patients with schizophrenia. If you look at some of the studies, especially a couple of meta-analyses looking at sleep disturbances and insomnia, insomnia and schizophrenia has been objectively validated at least in two meta-analyses. Okay. And nowadays, we consider insomnia as a prodromal symptom to decompensation. Somebody who's got schizophrenia and having insomnia, we are concerned that this person might end up developing or having an acute episode of psychosis. Some of the sleep characteristics of drug-naive patients with schizophrenia. Now, if you look at these two studies, look at SL stands for sleep latency. That means that this is the amount of time it takes for a person to fall asleep. This is total sleep time. This is percentage of stage 2, slow wave, REM, and REM latency, which means the amount it takes for a person to get into REM sleep. Now, if you look at this meta-analysis in these studies found that patients with schizophrenia have increased sleep latency. That is, it takes them a longer time to fall asleep. Look at the total amount of sleep is decreased. No differences are found between having slow wave sleep or REM sleep. However, according to this meta-analysis, patients who have schizophrenia or psychotic disorders tend to have reduced REM latency, meaning that they tend to go into REM sleep earlier than a normal person would. What about the other differences, or what's the difference, what type of sleep architectural changes we might see in polysomnogram in these patients? Some studies show that they may have reduced slow wave amplitude. Also, studies suggesting that they may have reversal in the phase of circadian rhythm, meaning that their days and nights might be mixed up. That is why you see some patients with schizophrenia tend to sleep during the daytime while they are up all night. Now, this could also be due to psychosocial factors, that patients with schizophrenia have difficulty being around people, and they tend to have occupations or activities mostly at night by themselves. Another study looking at the prevalence of obstructive sleep apnea. We talked about that obstructive sleep apnea is common in these patients, mostly because they end up gaining a lot of weight. There are cases of improved agitation on patients with CPAP. Some cases of treatment refractory psychosis remitted upon treatment with CPAP. Now, This doesn't mean that CPAP is going to treat psychosis as such. It is mostly because patients who have, say for example, obesity, hypoventilation, or really bad sleep apnea with poor sleep, and they already have psychosis, but when the sleep apnea is not treated, they tend to get more agitated, irritable, or if they have obesity, hypoventilation, they may have more CO2 in their system, causing them to have more confusion, agitation, and once it's treated, the symptoms tend to get better. However, I'm not meaning to say that CPAP is treatment for psychosis. We all know that that is not the case. Okay. Moving on to the mood disorders, what kind of sleep disturbances we find in patients who have mood disorders? Okay. Let's look at this case of a gentleman. Mr. John, a 50-year-old white male, presented with the following symptoms: depressed mood for more than 2 weeks, diminished interest in activities, significant weight gain, psychomotor retardation as observed by others, insomnia at night, and sleepiness during the daytime. A lot of fatigue, loss of energy, diminished ability to think and concentrate. Now, if you look at this, this is typical criteria for major depressive disorder. The patient underwent, he completed a questionnaire called Patient Health Questionnaire, which is used to screen patients with depression in primary care. The score was extremely high, 23 is a high score on that. Medical history of this gentleman had high blood pressure, diabetes, coronary artery disease. He was quite heavy, said 280 pounds, BMI was high. The gentleman was started on paroxetine, and 4 months later when he came back, his depression score was better. However, he was still not in remission. The bed partner told the doctor that the patient has history of loud snoring and also of witnessed apnea. The patient underwent overnight oximetry. As you can see, the oxygen saturation is dropping down to close to 70% or even below that. These desaturations they are significant desaturations suggestive of obstructive sleep apnea. So the question I have for the audience is that the symptoms look like symptoms of depression, but he has OSA. So does he have just depression or OSA or both? And as you all know, that the answer to that question is that he has got both depression as well as obstructive sleep apnea. If you look at this slide, you can see that these are the typical symptoms of obstructive sleep apnea, including snoring, witnessed apneas, and snort arousals. These are symptoms of depression, including sadness, anhedonia, guilt, agitation, and weight loss. But if you look at the center area, there is an overlap of these symptoms, including daytime sleepiness, fatigue, loss of energy, poor concentration, irritability, insomnia, and weight gain. So if you look at this, would be your typical depression patient, but this could be your typical OSA patient as well. So there's a huge overlap between the two disorders, and we need, as psychiatrists and mental health providers, we need to pay a lot of attention to that. Okay. If you look at several studies, especially this one by one of my colleagues, Amir Sharifane at Baylor School of Medicine, looking at veterans, soldiers, more than 100,000 soldiers. They looked at some of the database which they had, and they found that patients with obstructive sleep apnea had significantly higher rates of depression and other psychiatric problems. Excuse me. For example, 22% patients have, out of the OSA, 22% patients had depression, 17% had anxiety disorders, and 12% had PTSD. In another study, which was done more than 10 years ago, looking at a sample of more than 1,400 patients, they measured depression by Zung Depression Scale and were doing sleep studies every 4 years. They found out that patients who would develop OSA had almost twice the risk of developing depression. So if somebody developed obstructive sleep apnea, mild obstructive sleep apnea from no obstructive sleep apnea, the chances of that person developing depression was almost doubled. Similarly, if somebody moved from mild to moderate, their chances developed, and in the same fashion, somebody became severe OSA, the chances of depression became doubled as well. Now, what's the effect of CPAP on mood? So the question is, does really treating obstructive sleep apnea help with the mood or not? Now, looking at some of the randomized clinical trials and some of the other trials, including oral placebo sham CPAP, this particular review found that about 5 out of 7 studies showed some improvement. Now, there is question of having some placebo effect. Now, the duration of these studies were short, but they found that patients who had severe depression did better on CPAP. Now, these studies have big limitations, mainly that most studies did not have depression diagnosed by a clinician. The depression was diagnosed by self-administered questionnaires, and most of these questionnaires have several questions on sleep in those as items. As a result, if you treat sleep apnea, the sleep gets better. In turn, these questionnaires show improvement in their scores of depression. Okay, so reviewing obstructive sleep apnea and depression, it's to conclude, we can say that obstructive sleep apnea and depression are two comorbid disorders, and they have a very complex relationship. Rates of depression are certainly higher in patients who are OSA. Okay. Both disorders should be screened by a psychiatrist if a psychiatrist is seeing the patient, especially if they're treating a patient who's got obesity and who snores and complains of excessive daytime sleepiness. Treatment of OSA may improve depressive symptoms in patients with this comorbidity. And we all know that there's a lot more need to be done. We are going to be reporting a study which I participated in. We looked at a data of older men and found that older men who had obstructive sleep apnea tend to develop some depressive symptoms, if not severe depressive symptoms, as the time passes. Moving on, what's the relationship of insomnia and depression? Insomnia and depression have a very close relationship. If you look at several studies, for example, suggesting that 80% of major depressive disorder patients have insomnia. 40% of insomniacs report that they have some sort of psychiatric diagnosis. So if you look at, there is a huge comorbidity, and the field in particular has changed. If you remember, recently, or actually it's been a few years now since the DSM-5 came, they changed the criteria for insomnia and they changed the nomenclature as well. They no more recommend using terminology like secondary insomnia. For example, in the past we used to say that this patient has got secondary insomnia, secondary to depression, or secondary to bipolar disorder, for example. Now this term is strongly discouraged because we want to use comorbid insomnia or chronic insomnia, because if we say secondary insomnia, that in a way suggests that if you treat the primary disorder, insomnia is going to get better. And we know that that is not necessarily the case. And that's why we recommend that if somebody's got depression, for example, and they have insomnia, we want to treat both these conditions simultaneously. We want to treat depression with medications and therapy, similarly treat insomnia with medication and therapy, and should not think that the depression is going to get better and insomnia will get better as a result. Well, that may happen, but we cannot really depend on that. Let me show you that how sleep is more fragmented. Now, if you look at it, this is what we call as a hypnogram, which means that the time is going in this direction and we are looking at the graphical representation of the various stages of sleep. If you look at a healthy subject, the healthy subject is awake and falls asleep into different non-REM sleep, then goes through cycle here of REM cycle. So this is one sleep cycle, and the person goes through various sleep cycles, going through all the different stages and having REM sleep. If you look at this in patients who have depression, their REM cycles occur really quickly, meaning that they have a short REM latency. The sleep is a lot more fragmented, as seen by a lot of arousals here, but then also by increased activity of increased REM activity, as well as REM frequency and short REM latency. Now, these findings that REM is there is a short REM latency, meaning that the person gets into REM earlier than normal adults in depressed patients, is also found in first-degree relatives. There is also a phenomenon of increased REM density, which means that the rapid eye movements are more dense. There are a lot more rapid eye movements in patients who have uh, depression. What's the mechanism? What goes on? Why do they have these phenomena? We don't know. However, in the past, for example, in the 50s and 60s, when antidepressant medications were given to the patients who had depression, it was noticed that it reduces their REM sleep. And at that time, it was thought that maybe antidepressants work because they get rid of the REM sleep or decrease the amount of REM sleep. In many years, people used to think that. It turns out that that may not necessarily be the case because there are a number of medications which do not have an effect on REM sleep, but they in fact treat depression. What happens to sleep in other mood disorders? For example, in dysthymia or dysthymic disorder, there's a lot more fatigue than sleepiness. In patients who have atypical depression, there is a lot more hypersomnia. In bipolar manic phase, there's a decreased need to sleep. Not clear if meds help by improving sleep or by just their anti-manic effect. In patients who have seasonal affective disorder, they have features similar to atypical depression. They may have excessive production of melatonin as well. Moving on to alcohol use and sleep. What happens to patients who have alcohol dependence? Now, actually, we use alcohol use disorder, and what happens to sleep in these patients? Let's look at this patient, Mr. Daniels, 45-year-old male who presented with insomnia, poor quality of sleep, feels unrefreshing during the daytime when he wakes up, consumes about a 12-pack of beer a day, which is quite a bit. He misses days at work because he's sick at times or he's too tired. Could he have a sleep disorder, or could there be a sleep disorder playing a role? So let's see. People have any thoughts? Well, you can certainly have a lot of sleep problems because alcohol can cause a lot of problems with sleep. For example, alcohol can actually put people to sleep. However, the effect is there in the first half of the night, they may have increased slow wave sleep, decreased REM sleep, but the second half of the night when they're kind of going through withdrawal, the sleep becomes very light. There's a lot more awakenings. There's a lot more sleep fragmentation, which makes things worse for these patients. Now, if you look at this, this is a typical hypnogram. A person is going through different sleep stages, REM cycle, different REM. This is what happens. Somebody who drinks alcohol and goes to bed. They go into deep sleep. They don't have REM earlier part of the night, but the later part, their sleep becomes extremely fragmented. Chronic alcohol use, it increases the sleep latency. There are a lot of patients who are they have chronic alcohol use disorder. They have decreased sleep efficiency, decreased total sleep time. In addition to that, they have decreased slow wave sleep and also decreased total REM sleep. Now, this is a diagram which has been taken from this particular journal. It talks about how patients who have insomnia, they drink alcohol to self-medicate. As a result, they tend to have more toxicity, which in turn can make them have more insomnia. Now, the treatment is abstinent, but then they tend to have persistent insomnia because patients who even stop drinking alcohol tend to have problems with insomnia. And persistent insomnia by itself is a risk for relapse because they tend to drink alcohol to go to sleep. Okay? So there is a sort of a vicious cycle which it becomes very difficult for them to get out of. Okay? Now, alcohol may also exacerbate other sleep disorders, including periodic limb movement and restless legs and obstructive sleep apnea. Okay? This is an example of how the patients who have alcohol consumption tend to have a lot more periodic limb movements of sleep. Alcohol also reduces the genoglossus activity, which is a tongue muscle, which is the tongue, prolongs time to arousal, leading to prolonged apneas. Okay? Now, this is a case from back in the 80s, this case which was published to show what alcohol can do to oxygen saturation. So this is somebody, 53-year-old male, who's a social drinker, but this is He has history of snoring. This is oxygen saturation, and it's pretty normal. As you can say, it is staying about 90% throughout. So this person, even though he snores, oxygen levels are not dropping down. But what happens to this person when he just has a few drinks? This is the second night when he had about 8 to 10 drinks. Look at the oxygen saturation here, how badly it is affected, even here. So the same person, if drinks alcohol, can have a lot more sleep apnea than if they don't drink. So going back to our gentleman, Mr. Daniels, he underwent a sleep study, found that he's got severe sleep apnea, was treated with CPAP, was convinced to obtain counseling from substance abuse people. Residual insomnia after abstinence was treated with Neurontin or gabapentin. Now, gabapentin is nowadays the drug of choice for patients who have alcohol use disorder and insomnia. There are several reasons for that. Number one, gabapentin does not cause seizures. It's actually an anti-seizure medication. Number two, it may help with some sleep, though with insomnia, even though it's not the best drug, it's not a panacea. Number three, it helps with periodic limb movements or restless legs. And actually, number four, that it does not go through the liver. So if patients who are using alcohol have trouble with liver problems, we can avoid some of the medications which go through the liver and use the one like gabapentin, which doesn't go through the liver. Now, to conclude, I'm going to say that sleep disorders are intimately tied to mental illness. This is true both at a clinical and at a neurochemical level. The field has changed quite a bit, where now we know that there is a bidirectional relationship between sleep disorders and mental health problems. That is, insomnia can trigger episodes of depression and vice versa. An understanding of sleep and psychiatric disorders relationship will help us with treatment for both in the future. Now, I'm going to stop here and see if there are any things which I can